All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's topic is, in the words of our own guest speaker, on palliadelic health, relieving suffering by revealing the mind. Our distinguished guest today is Dr. Lou Lucas, whom CAPC has graciously connected us with. Dr. Lucas is an associate professor of palliative medicine and neurological sciences at the University of Nebraska Medical Center and the chief of palliative medicine at the Nebraska and Western Iowa VA. She is the primary investigator for an exploratory trial exploring a psilocybin and IFS-based intervention for distress related to advanced GI cancers, and the site PI for a phase 3 trial of psilocybin for major depressive disorder. So with that, thank you so much for joining us today, Lou, and I will hand the mic over to you.
Thank you very much. I appreciate your hospitality, and I'm very glad that you gathered some questions. And so I just decided to call this Psychedelic Q&A today because we're going to address the questions. And if people have questions along the way or have new ones, do they put them in chat or Q&A, or how do you like to do that? That we'll just put them in the chat?
Yeah, that's perfect. Sure.
Sounds great. And actually, if they're in the chat, I can see them as they pop up, and I might fill out other, it'll help inform other questions.
Great.
So welcome, everybody. I'm a little disappointed that I didn't get the like psychedelic background under psychedelic on this slide, but we'll make do with what we have with black and white. My main goal in all of this is to balance hype and hope, because we know that there's a lot of hype, and actually some of the recent news has helped deflate that balloon just a little bit. But being aware that there's enormous potential in these substances, and there's a lot of fluff and garbage and BS out in the market, and really trying to walk the line between those and develop as close as we can get to empiricism with a field that kind of crosses some boundaries in terms of how do we understand the mind, how do we understand our perceptions, how do we understand the balance between rigorous science and things that we don't yet have good labels for. So I always want to try to walk the line between those two. So I don't want anybody to take this as an endorsement that everybody should run out and do, an ayahuasca journey. And I hope that if there are people who are cynics in the crowd, that you can kind of get a sense of the potential that are available in some of these substances. A quick review of psychedelics. And so this is a survey of all or most of the natural psychedelics. If we move from our friend, the psychedelic mushroom, this is a psilocybe mushroom. This is the toad, the Sonoran River toad, and these glands secrete something called 5-MeO-DMT. This is the root in the bark of some South American Amazonian plants that make ayahuasca. This is ibogaine that has been shown to have some significant impact on heroin addiction. This is the San Pedro or the peyote mushroom. I'm sorry, cactus that mescaline is derived from. And this is a shaft of rye, like the grain rye. And this nasty little stuff here is rye ergot. And that is what LSD was originally, or that the chemical that's in there is very close to LSD that was later synthesized in the 40s. And this rye ergot is what a lot of people attribute many of the interesting things that happened in that are reported in the Middle Ages of Europe, of like whole cities going mad, or some of our mystery cults and things would have used this form. And this just says that they're ubiquitous in nature. There are a couple of animals, there are no insects. Many plants and fungi produce psychedelic substances. So throughout history, most peoples have had access to natural psychedelic substances, and mostly they used these in rituals related to healing, and the ways that they conceived of healing, which was body, mind, and spirit, not just physical healing. These are also synthesized prolifically in labs. This is what the study substance for the MDMA for the MAPS trials looked like. We use ketamine in the ER and now in psychedelic assisted therapy. These are actually the original bottles. This is indicybin, which was Sandoz's formulation for psilocybin back in the 60s. And this is Delicid, which was also produced by Sandoz, and it was marketed in the 40s for depression. Actually, they would have called it neuroses, substance use disorders, and the existential distress related to cancer and other forms of end-of-life care. So these were all manufactured. And interesting, I don't know if you guys have heard that there were almost 1,000 papers in the medical literature between the 40s and the 70s about psychedelic substances, and then they were completely buried after the war on drugs started. So because the questions came in different formats, I thought I would just review the classes of the psychedelic agents, because psychedelic was used originally to define what we call the classic psychedelics, or the tryptamine-based psychedelics. And those include psilocybin, LSD, DMT, which is the active ingredient in ayahuasca, mescaline, etc. And that class falls into two different chemical formulations, one of the tryptamines and one of the phenylethylamines. So the phenylethylamines include mescaline, and that's a little bit like a more dopaminergic agent. And the tryptamines are serotonin-based, or very similar to serotonin, and use that pathway, but they produce very similar substance effects. And then we have the dissociative anesthetics, and that's ketamine, which is related to phencyclidine for people who remember PCP, or angel dust. And all three of these categories of agents, oh, I'm sorry, the phenylethylamines also include MDMA. But so we call those guys sort of the non-classical psychedelics, the ketamine and MDMA, because they produce an altered state of consciousness, but not those vivid pictures that you see. And then we've got classic psychedelics that are the tryptamines and the mescaline. And then we've got a class of agents that we don't have really good names for yet, like the 5-MeO-DMT, which people call a transcendent, a profoundly different state of consciousness, but again, not that stereotypical picture of the black light poster or the fish concert or the dancing bears or all of those kinds of visual images that people get with the classic psychedelics. And they have similarities and they have differences, but from a medical point of view, we have to be really cautious of not lumping them together, because they have very different side effect profiles, and all of the contraindications and things that go along with them are different based upon the chemical structures of the drugs. So I'm going to just take a sip because my throat's a little raw. Give a quick update on MDMA, because that's transpired since the time these questions were derived. A lot of people have heard about the news. People are saying, oh, the FDA didn't approve MDMA. And that's actually not accurate. The most recent news that people have heard was an advisory panel that is convened by FDA. And there were interesting issues that we won't go into here about that panel and the nature of the discussion that they had. But even on a normal day, the FDA disagrees with them about a third of the time when they recommend against a drug. So when they recommend against a drug, about a third of the time, the FDA goes ahead and approves it because of other things. For this drug in particular, it's interesting that the organization supporting it, MAPS, which is now called Lycos, had an agreement with the FDA about the specific design of the study. And the FDA was actually actively involved in the design of the study. And they recognized the things that some of the comments were critical of. And so that will probably increase the probability that it would be approved, but it certainly doesn't make it a sure thing by any stretch of the imagination. But the key issues are two, the science and the potential harms. And the science is actually pretty good. And when you consider the nature of the problems that we're treating, the science is really quite good at helping people who are in horrible distress because of serious and refractory PTSD. The science, however, isn't perfect. And some of it's due to the nature of these substances, because it's simply impossible to blind a participant to a consciousness altering drug. So we have some tricks we can play in terms of dose, but you can't put somebody on a psychedelic trip and tell them that they really didn't have one, and vice versa. So that poses some challenges in the way we typically view rigorous science, because we like double-blinded placebo-controlled substances, but you can't blind the effects of these. The other thing that is challenging with these substances is it's incredibly difficult to capture the transformational change that people experience with validated measures that are usually standardized and simply don't capture the totality of the human experience. And I think in palliative medicine, we're well aware of that holistic view of patients And many of the tools that we have are sort of mechanistic or reductionistic and don't quite match them. And so there's some issues there between mismatches of the science and the problems. But there are real harms that need to be addressed. And the main thing is our system, both our culture and our medical system, are not designed for these substances. The main problems that they were concerned about were therapist transgressions. That's certainly not limited to psychedelics, but psychedelics might increase the likelihood of it because people might not be as aware of those transgressions. There are diversion issues because I don't know how many of you are living in communities where any Sam, Dick, and Harry can put up a ketamine clinic these days, and some of them are fabulous psychotherapists who are doing wonderful work, and some of them are people hanging out a shingle and tanking people up with some drugs in dark rooms with their eyes taped closed, and then wondering why there are side effects. So we really have to think about how our implementation will work as these drugs become approved. So overall for MDMA, the thought is that it will eventually be approved because it's quite powerful, and we just need to get a handle on how we deal with the harms, how do we roll it out, and how do we make it safe for people who are there. The FDA is supposed to give us an official ruling on the current application in August. They always have the right to delay, but we'll know one way or the other how that will go. And in the meantime, we'll wait and see what happens. So there were questions about MDMA. The main interactions and counterindications include we don't want to give any of these agents to people who have psychotic disorders or predisposition to them. And that includes people who have bipolar disorder, particularly type 1, people who are predisposed to mania, particularly with MDMA. But the psychotic disorders and bipolar are also common to the classic psychedelics. Cardiac conditions are much more worrisome on MDMA because the MA stands for methamphetamine. So methamine dioxymethamphetamine is an amphetamine, and it comes with the increased heart rate, increased blood pressure. There are issues with QT. There are some concerns about arrhythmias. So people with pre-existing cardiac conditions, we need to be quite careful of. The drugs we're worried about are MAOIs. Not very many people are on them, but they are certainly contraindicated. There's SSRIs are more concerning for these agents, but they're still probably possible. At this point, most of the trials would have taken people off of SSRIs. From a theoretical point of view, they may actually be okay, but of course, we're not prescribing these, and I'm not giving you any advice on how to blend these substances. Other amphetamines certainly cause problems with all of the side effects we mentioned above. And MDMA is metabolized by the cytochrome P450 2D6 mechanism. And so a lot of drugs modulate that. So we will have quite a few contraindications of various degrees of harm when this eventually comes to market. People asked about the Tuesday blues, and the Tuesday blues are specifically unique to MDMA. MDMA, the effect of MDMA provides a flood of serotonin. It changes the serotonin transport mechanism, and it dumps tons of serotonin into those synapses and just lights up that whole network. And in doing so, it has two main effects. The first is that it just makes you extremely relational. And so people are like, oh, I just want to dialogue with you. And so you can imagine for people with PTSD who might not trust anybody, to be in that state where they can actually develop a therapeutic relationship with someone, that drug is extremely helpful. And then on top of that, it basically turns down the volume on the amygdala, and the amygdala gives us our fear signals. And the fear signals are enormous in people with PTSD. But you know who else they're important for? People who are undergoing life-threatening illnesses. So I can imagine using this substance well within, not necessarily for PTSD in the way that the MAPS trials are set up, but to use it for, what about using it for family meetings? But to get back to the Tuesday blues, if we think about that huge dump of serotonin, well, when that kind of is depleted, it takes the cells a while to get enough serotonin back in to conduct their normal business. So if you did your MDMA or your ecstasy on your Saturday night dance party, by Tuesday you'd be really depleted of your serotonin, and so people have a little bit of a problem on Tuesdays, and that's where the Tuesday blues came from. So other people asked, is this therapy too burdensome to use in hospice and palliative medicine? So the MAPS model for PTSD is a lot of therapy, and it would be probably too much for the average hospice person who's quite ill and may not have much time, particularly when you're thinking about people, if our average is still around a month on hospice, that's a little too far downstream for that. But I can absolutely see using this in family meetings just to allow people to let down their boundaries a little bit, to turn down their fear a little bit, and to be able to talk about things that are frightening to them. And I think that there's great application for MDMA that we can use at virtually every stage of the process. It'll be a little more challenging as we figure out, is it safe or not safe for people who have more advanced illnesses, especially cardiac illnesses? But overall, I think it's going to be a good agent for us in the future. There's just not much research on it in our field. So now I'm going to switch gears and talk more about the research or the classic psychedelics. So we're switching from the MDMA class, the empathogens, over to the classic psychedelics and those tryptamine-based drugs. The scope of research is growing quickly. The depression research has been quite good. And we're finding the best research and the absolute largest effect sizes are seen in people with cancer and other end-of-life conditions. And I'll talk a little bit about that as we go along. Depression is being very well studied, and that's the indication that's going to go to market. And it may be available to us in 2026, 2027. And what we're finding is that not surprisingly, depression is different than the distress that we see in our patients. And so some people have a response similar to the cancer patients. Some people have a response for a while and then it dissipates, and some people don't get any response at all. The next indication that we're going to see is various substance use disorders, and this is extremely effective for both tobacco and alcohol use disorders. The recent data that I saw from the tobacco studies is that the people in the trial, there's an 87% chance that if you were in that trial and you took that, if you took your psilocybin and CBT intervention a year ago, that you may still not have smoked a cigarette. They've been following people, and it's just nothing produces results like that in the addiction world. So that is progressing quite rapidly. And then beyond that, there's just an enormous scope of things that the classic psychedelics are being tested for. PTSD, eating disorders, cluster headaches, chronic pain, irritable bowel syndrome, neuropathic pain, and on and on and on. And we're just learning about how our neurological system, how our psychology impacts all of these disorders. So when I started my trials, there were 27 trials in clinicaltrials.gov. Now there are over 150 for psilocybin alone. So it's just exploding, and we are going to see a real impact on healthcare overall. But we have to learn how to use them, and that's the balance of those two things. Someone else asked, why do we think about demoralization, or why is most of the literature in hospice and in palliative medicine using demoralization as a measure? And that's the pragmatic reason is that it's better than depression for what we see in palliative care. In depression, the symptoms often overlap with medical illness. So when we're looking at a lot of the tools that we use to follow depression, we run into problems because, are you tired? Have you lost your appetite? Well, if you're on chemotherapy, you're tired and you've lost your appetite. So it's hard to use those tools, but it also doesn't capture things. So the demoralization tool, and most people are using one called Demoralization 2, or the Demoralization Scale Part 2. And it better captures meaning in life, purpose, and coping. And so we think those things have more application. But here I'd really draw that parallel that we saw with the MDMA and the problems that they're having with the science behind it. Because using a validated tool, and usually we're talking about, maybe people are answering 10 to 20 multiple choice questions or 10 to 20 scale of 1 to 5 questions, and they simply don't capture what people are telling us. I studied with the people at Johns Hopkins who really opened this field in the 1990s. And they were very well-trained drugs of abuse researchers. And they were stunned when they talked to people after this, and they did all of their measures. But they also found that people were saying things like, this is the most meaningful experience I've had in my life, or this is on par with like watching my child be born, like the feeling I have of the awe and the openness and the connectedness. It's that kind of a feeling. In my trial, I've been working with people who have pancreas cancer, and we're expanding it to the up to other GI malignancies. But the last gentleman we treated said at the day after his his drug dosing treatment, said, I feel like I've lost 250 pounds. And I said, tell me about that. And he said, I didn't realize I was carrying stuff. I didn't realize I had this tension in my body. And he used to describe himself as feeling vulnerable. And now he says, like, I realize like I can be open. I can, and to be able to capture that in a validated measure that you can replicate over many people is really hard. And so interestingly, in the trial that I'm doing, people don't say they're like, they didn't say like, oh, I'm not really very depressed. Oh, I have a little bit of anxiety. And it's only afterwards that they realize like, oh, those things that I were feeling, maybe that was depression, but they wouldn't have screened positive for it before. So you don't have a pre-post comparison. I have another subject who had just this enormous epiphany of like of something that happened to him when he was a child. Is I found him. I found a little boy, and I told him it was going to be okay, but he was going to have to go through some really hard things, but he was going to end up okay. And I just gave him a hug. And after that, he again said, like, I knew that I had had these bad experiences, but I kind of kept them in a little file, and I didn't really I knew it was there, but I didn't deal with it. And when I found that, I just had this release of all this energy I was using to hold up and pinned up those things. And so finding ways to measure these are always going to be a challenge for us. And we'll have to balance that with the hype that might go along with some of it. Another question was, are psychedelics too upstream for hospice and palliative medicine? And I say in palliative care, I want to make sure that I'm a little more inclusive. I'm just used to AAHPM when I fill out my things, so I tend to put the M on there. So probably not. I think that there are lots of applications, and that you're going to design your intervention, which might include different levels of dosing, different levels of frequency, different agents, depending upon the circumstances. My colleague Yvonne Besant at Dana-Farber and Community Hospice have a lovely study that's going on in hospice, and they're doing dosing sessions in people's homes. And then my recent patients, I've had people who are quite ill. Unfortunately, one of my trial participants who was just dosed in May had a lovely experience, but had very advanced disease, passed away. And he was ill, but he was still ambulatory and doing, he was quite functional, and he was able to participate. So I think that we will just craft the interventions to fit the specific need that we identify. And when you think about that scope of research, we're going to be able to find lots of discrete uses for these agents. So big questions about interactions and contraindications, which is of course very important. The same things about psychosis and mania, personality disorders that would prevent a therapeutic relationship, because it is that therapeutic relationship and the feeling of safety and trust in the dosing experience that allows people to have a better, deeper dosing experience. From a medical point of view, the main thing is that we would have to exclude people who would have an inability to tolerate a 2-hour increase in blood pressure and heart rate, because these agents are sympathomimetics. They're not like the amphetamines, but they do increase heart rate. They do increase blood pressure. In most people, it's negligible. But if you have significant cardiovascular disease, if you have CBA risk, if you have kidneys that are functioning on just the right amount of pressure, a little bit too much might be too much. So we're going to have to figure that out. Right now, I'm in the midst with some colleagues of putting together a proposal for NIA, the National Institute of Aging, has just released a funding opportunity for chronic pain in the elderly using psychedelics. And their first step is all about safety. So hopefully we will be discerning some of these issues through that, if we're fortunate enough to be funded. The agents that we're going to exclude, the drug agents, SSRIs and other serotonergic agents have been excluded from trials because of the theoretical possibility of serotonin syndrome. More work and understanding of serotonin specifically, and the other agents more generally, is that serotonin is not released, or the serotonin that's in the synaptic cleft is not increased during psilocybin sessions. And because you need a serotonin syndrome comes from excess serotonin in that system, it's not likely that we're going to run into serotonin syndrome as a problem. Again, we're also only using this once, and it's a relatively low dose, so it's a very low risk at any rate. But many trials, so in my GI cancer trial, we're not asking people to stop their SSRIs, their antiemetics, et cetera. We just feel like the risk benefit is adequately controlled. And there have been a couple of trials now that have looked at concurrent use of SSRIs and SNRIs with pre-treating and seeing what the impact is. So the safety issue is probably not the problem. However, they could make the experience different. And so we don't know how they're going to impact efficacy. So that's going to take some additional work. Antipsychotics will abort or prevent the psychedelic experience. Benzodiazepines will probably constrain people from having an experience, but low doses might be tolerable. And we have been allowing people who use small doses for insomnia to come into trials at large. And then the classic psychedelics are eliminated through the UGT system as opposed to the CYP system. So if there are only a few drugs that are modulated by this system, but they need to be avoided. And like probenecid comes to mind, and there are a couple of other agents that are so uncommon that I'm not familiar with them. We don't have them at hand. But again, we'll watch for those specific indications when the approvals come through. Then there are a lot of people, people who are excited by this really want training, and sometimes they're seeing patients who really want those experiences because they've been hearing about those things. And this is, I think, the trickiest thing at this point. The training is dicey, and it depends on what you're aiming for. In terms of training, to be able to work with these substances and to work with people who are using these substances therapeutically, the most important work is self-work. It's and so many of us do that, and we just need to deepen it so that we can reach the level that people are at when they're in these psychedelic experiences. Because some of the training that I took was called working with the unbound mind. How do we, if we think about ourselves as normally being constrained by layers of defenses, Martin, for example, said, now you're going to be on camera, so don't pick your nose. But we have like defenses all the time. We like, okay, I'm going to suppress little things. I'm not going to pick my nose. I'm not going to make noise. I'm not going to do these things. And a lot of times I'm not going to feel my feelings, or I'm not going to let my feelings show. When you're on these substances, those defenses go away. And so we have to be prepared to be with people who are in that. And in palliative care, we see so many people who have heightened states of emotion. And so then if you amplify that by 10-ish, that's probably, and maybe more, depending upon how profound the person's experience is. How are we present with that without running to save people, without panicking, without taking on the experience ourselves? So self-work, self-work, self-work. Being in a personal therapy, being in a meditation practice, being involved in group supervision where you are ruthlessly honest with each other, being willing to explore your practices. Every time you feel a trigger, working on it. That's where the real training is. I would encourage you to look for live instruction as opposed to watching a bunch of videos. You can get something from that, but I feel like those people who are trying to mass produce it might be a little bit less useful. So you want a balance of live instruction where you're actually able to be in dialogue with someone, that you need to have supervision, that you are able to work with people who are in altered states of consciousness, and you are able to be supervised by people who are in altered states of consciousness. And I heartily recommend, and in fact, if I were in charge of this at the state level, I would require experience with these substances to be able to practice. Because as one of my teachers said, like, so what does it mean if the person who likes to sit out on the boat and is afraid of the water, or is unable to tolerate, a snorkel mask or something, why should that person be so interested in training people to go under the water and learn how to be down there? That if you don't have the experience, teaching someone how to have the experience or helping them prepare for that experience is really challenging, because It is like nothing else you've ever been through. It fundamentally changes the way you perceive things, and there's no way to adequately explain it to someone, but at least having a sense of the distance you are from your normal self helps you prepare people. And so far, I've heard, as I've done consent with a lot of people, they ask me about my experiences. And in case I didn't start this presentation by saying it, I became personally involved in this work over a decade ago because I was a healthy volunteer in one of the Johns Hopkins trials. So I've been through their protocol twice. And then I did experiential training in Europe after that. And so I think it's quite important if you plan to become a practitioner of this, that I would look for training that provided that. And of course, right now in the US, MAPS did have a protocol, but no one else has gotten a training protocol through. So we have issues about how we're going to train our providers adequately with that. So the training is dicey. There are a lot of people out there. Some of the training is very good. Some of it's really iffy. And I think you can wait a little while because most of us are not going to be providers for a while. Look to your academic institutions and see if they're doing research. And then people asked about patient experiences. The only legal, federally legal product that we can use at this point is ketamine. And ketamine can be quite effective. It has natural antidepressant properties just by virtue of its pharmacology. And in the right dosages that are adjusted for the right person, you get an altered state of consciousness, and it probably induces some neuroplasticity. So if you have a good provider, you can ask them to find it or you can refer them to a good provider who is using ketamine. There are underground opportunities, and first, it's illegal, it's unregulated, and I know many underground practitioners, and some of them are fabulous, and I would trust them anywhere. But you don't know who they are, right? And so it's very uncertain what you would be referring people to in the underground. And I have seen entirely too many people who, went to South America once, put a feather in their hair and called themselves a shaman. And that's really dangerous because people need better boundaries and better care than that. And of course, you can go overseas. You can go to Peru or Costa Rica or any number of retreats that are over there. And so it's not any more legal. Well, actually, in a couple of countries, it's legal. It's not illegal back here. It's unregulated, and you're a long way from home. So bad things happen. You don't have as many resources available. So it's a real dicey experience. I would not recommend people unless you know a good therapist and that therapist is working well with ketamine. That's a good viable option. But otherwise, I think it's really unethical at this point to refer people outside those experiences. We do have Oregon and Colorado for the folks who were there. And there we have mixed results. We're learning, we're flying the plane while we're building it, and so each of those states have their own regulations and their own sets of things. Most people are not supposed to be going for treatment. It's supposed to be for, or I think in Oregon, it's not for treatment. It's just for, sort of retreat, like betterment of well people use. In Colorado, they're trying to figure out what that blend is. But on the federal level, it's not legal for people who have licenses. So we're in really uncertain waters when it comes to those things. And as I said earlier, like overall, we'll see. We are at the very beginning, like we're at the end of the beginning stage of psychedelics, and we're at the very, very, very beginning of the middle stage. We're not even at a point where at implementation yet. So I think that's the end of the prepared remarks that I have. I hope that I showed you a little bit of both the hype and the hope that we've got here. And if people have more questions, I'd love to hear them.
Thank you, Lou. I really appreciate it. It sounds like this is going to be a ways off until this becomes mainstream. If it becomes mainstream, we're talking.
Well, MDMA could be available next year. Like
Wow.
if the FDA could approve it. So if they do, it will be available next year.
And yet, things like buprenorphine, ketamine have been available to the palliative care service line for a long time, and it takes a while, I think, for those things to sink into what people are comfortable with.
Great.
I
Are there
know that
questions? Or
I
do we
know
have time?
Yeah, there were a couple of questions in the comments. If you wanted to answer a few of those, if you'd like to, that'd be lovely.
You know what? I cannot see the comments from what I'm looking at right now. Can you read them?
Absolutely. Absolutely. So first one is, if a patient is interested in these treatments, is there a database? But I think we already kind of had the answer to that, not yet at this point, as it's not legal quite yet.
Right, and it depends. If you are in Colorado or
Mhm.
Oregon, they're legal on the state level, and there's no reason to suspect the feds are going to jump in at this point.
Mhm.
The DEA certainly has not taken any action in those cases, and they've constructed them in such a way. So those states are possible, but there's a difference between your patient seeking things out and you making a recommendation.
Mhm.
And so I would be cautious of where are you as a provider,
Mhm.
and you can tell them things to look for, um, but it's mostly people doing their due diligence in those legal settings.
Not unlike THC. I mean, there's some research where we can advise for different side effects, what they might expect, but we may not be able to necessarily prescribe.
Exactly.
Let's see. There are a couple more questions that were similar to that. So we'll skip ahead. There are two more. This one from Lisa says, you mentioned going to Europe for training. Are there treatments available there that are more advanced in their use?
There are some workarounds.
Mm.
So some of the countries in Europe have very slightly different laws or have regulated things in a different manner. And so there are some legitimate opportunities there, and they come and go. The organization that I trained with have stopped doing that part of their service line, um, because they've diverted their resources elsewhere. So I can't make a recommendation, but Europe definitely has uh, a somewhat more liberal attitude, and Australia has recently changed the regulation. Both Australia and Canada have different regulations resulting, and I want to say that Australia just recently actually approved psilocybin and MDMA for use.
Hmm.
But again, I don't get down under very often, but there was a lot of news just recently about that. And then Canada has some capacity to do um, um, they have a different word for it. It's what we would call compassionate use. So they're talking about that more frequently. So there are going to be opportunities
Hmm.
in those areas. I've not haven't been training for a while. So uh, if I were looking for training, those are three places where you might be able to find something that's more well regulated.
Hmm.
The one place that I would recommend that certainly has the most prestige within the U.S. Would be CIIS, the California Institute of Integral Studies. And they're a university, Naropa University in Colorado. Again, it has an academic foundation. And they're offering a degree and a certificate program. So those are definitely going to be more comprehensive, better based. The Institute of Integral Psychiatry offers a program that's very legitimate, but and they would offer, many of these would offer opportunities to dose with ketamine as a way of getting some sense of experience of what it's like to be in an altered state of consciousness. So those places might be places that you could look. But again, unless you're in a place where you're going to be able to use it, I would kind of wait and see how it plays out.
Excellent. Could you give us that name one more time? The one in Colorado?
In Colorado, there are a couple. It's Naropa, and it's either NAI or NIA,
Okay.
or
Perfect.
ROPA, Naropa.
Right.
And then it's IPI, and it's the Integral Psychiatry Institute.
Perfect. And then one last question for Becky, and then we'll send you off. It is, could you ever see any of these trials or therapies, including patients with psychosis or mania, etc., who also have issues with depression, PTSD, or end of life?
Yes, but not right away. Um, we will move into that territory, but we don't, research is all about protecting participants from harm. And so we only move as quickly as we can feel certain that we're balancing the risks and benefits. And so that's going to be some of the more risky territory, because there is potential risk for that person and figuring out how we would ameliorate that risk if they were in a psychotic episode and they couldn't get out of it. That would be quite dangerous. And then if you're going to do that work, you are doing that work at the expense of doing work that might help many more people without that risk profile. So I think it's going to be a while before we see some of that work. We will see it, but I think it's not going to be soon.
Perfect. All right. Thank you, Lou. It sounds like this is an exciting thing that's going to keep growing during our career and our lifetime. We really appreciate you being with us today.
Thank you very much. I appreciate your hospitality. Bye.
Absolutely. Bye, everybody.